Hello everyone, it's my very great pleasure to be with you today. I'd like to thank the conference organisers for their generous invitation, and as much as I would like to be there with you in person, it's still great to be here from Naarm in Melbourne, in the land that we call Australia. I'd like to begin by acknowledging the traditional owners of the land that I'm on today, the Wurundjeri people of the Kulin Nation, and pay my respects to elders past and present. I'd like to acknowledge that I'm on unceded land and there's still much work to be done here. I'd also like to acknowledge that I'm a white settler. I don't have lived experience of racism, but I benefit from white privilege and supremacy and see it as my job and those who are also white to be allies and to contribute to dismantling those systems of white supremacy. So that's the position that I'm coming from. I'll be talking to you today about racism and its effects on children and young people, and I'm sure you've had fantastic presentations already this morning giving you an overview of racism, how it impacts on health and well-being around the world, and on maternal health. So I'm sure it won't be new information, and it will be something that is intuitively as well as scientifically known by many of us that childhood sets the foundation for lifelong health and well-being. There's very strong evidence now from developmental science, from life course epidemiology, to tell us that early life experiences and exposures get under the skin and become biologically embedded to influence later outcomes. We also know that as well as the early years being so important to lifelong health, that adolescence is another time of peak time of biological change, as much brain developmentally change as in the early years by some studies, and also of social role change where adolescents and young people are navigating who they themselves are in the world and in context of those around them. We also know from life course epidemiology and life course theory that early and ongoing socially patterned risks and opportunities, such as those that are patterned by race and racism, lead to health and developmental advantages and also disadvantages, and that contributes to lifelong health and well-being. Conceptually, we often talk about this accumulation of risk that happens throughout life, even from preconception. We also often talk about a chain of risk concept where, a bit like a string of dominoes, that one event then triggers another one and sets up a trajectory of either opportunity or of risk in terms of lifelong health and development. Some of you may have already heard of this concept of weathering, and we've got a picture there on the left of a pretty worn down and run down building that's been exposed to the elements and deteriorated. But if we had another building alongside it that perhaps had been not exposed to as much weather, as many storms, perhaps was in a much more sheltered part of the neighbourhood or of the environment, we would see that that building hasn't deteriorated anywhere near so quickly. And we can think about children and young people and lifelong health in a similar way, that if a child or young person's body experiences a greater burden and an accumulation or a chain of risk in terms of these stress or exposures, that their health and well-being across multiple outcomes is going to deteriorate at a far greater rate than another young person or child who's exposed to many more opportunities and far fewer risks. We also know from life course work that age and time are not only biologically significant and developmentally significant, but also socially significant in terms of the different contexts in which children and young people grow up. So, for example, in the very early years, the family environment is key in terms of what exposures, what risks and opportunities might be particularly important to health and well-being. And then as a child enters school, different contexts, school, peer, the social environment changes. And then, of course, as an adolescent becomes much more independent from the family, the context, and perhaps starts to go to work or higher education. So we need to think about age and time, both biologically and in terms of social context and social significance. We also know that childhood sets the foundation for lifelong attitudes, beliefs, and behaviours. It's particularly important in terms of identity formation and children and young people understanding who they are in the context of wider society and their value and worth. From infancy, infants recognise racial ethnic difference. There's a number of studies that show that, and by preschool, in-group preference can emerge. In middle childhood, children can be aware of stereotypes related to skin colour and of out-group biases, and have the cognitive and social and emotional skills to recognise overt and covert discriminatory behaviour. So it's very much a myth that we shouldn't talk to children about racism, or that young children and young people don't experience racism or don't understand what it is. There's a study on the right hand, I think my video might be obscuring it a little bit, but a study that came out in the US in the last couple of years showing that children and young people were ready to talk about racism about 5 years before adults thought that they were ready to have those conversations. We also know that adolescence, as we mentioned before, is a key time of both biological change but also of social identity formation and moral development, where experiences of racism and attitudes about race and racism are key and foundational to lifelong outcomes. So in this context, race and racism profoundly shape health and health risks and opportunities for children and young people, with consequences throughout life and indeed across generations. So we can say that children and adolescents are particularly vulnerable developmentally, biologically, and socially to racism's harms. How do these harms occur? They occur in multiple, complex and reinforcing ways that continue throughout life and across generations. It happens at a structural, societal and institutional level through historical and contemporary racism on communities, families, carers and their access to resources and opportunities, as well as direct exposure to racism itself and pathways of stress or exposure. It's a really helpful model that colleagues Natalie Slopin and Nia Hurd-Garris published last year in JAMA Pediatrics that I would commend to you. It is based on a US context, but certainly be great to adapt it to other contexts as well. So they highlight how structural racism is driving these pathways of inequities and of experiences of interpersonal racism. So structural racism, and we'd put colonisation as an expression of and a driver of structural racism, of course, that then drives race-based residential segregation. Here in our context, here in the land we call Australia, we'd talk about removal of Indigenous peoples from lands, of disruption and forced removal of children from families, forcing families not to participate in cultural practices and so on, and leading to segregation of school, of occupations, of poverty, criminal justice system and mass incarceration inequities and so on. That then leads to inequities and in social determinants, which I'm sure many of you are familiar with social and physical, environmental determinants of health, whether it's neighbourhood safety and quality, housing security and quality, education, food security, the quality of the environment, air, soil, water quality, pollution and so on, and the quality of healthcare access and opportunities as well. That then leads to interpersonal racism, both at an implicit and an explicit level, and directed both towards children as well as towards caregivers and other family members, what we often call second-hand racism, which also has impacts on the health and well-being of children and young people. And you can see some of the ways in which this happens. So if there's both through these social and physical determinants, environmental determinants of health, that of course is going to impact on the ability of families and communities to provide optimal caregiving and child development environments. So is if a caregiver or a family member experiences interpersonal racism, that's also going to impact their own health and well-being, or their ability to obtain work or education or appropriate housing, which also then can lead to these developmental changes in responses to environments that we were just talking about at a neurodevelopmental level in terms of programming of the stress and immune systems, or epigenetic alterations. These then accumulate and lead to inequities across any outcome indicator that you care to mention. Quickly, some examples of how this looks here. You can see here, as many of you may have heard, persistent inequities in the removal of Aboriginal and Torres Strait Islander children from their homes into out-of-home care. Ongoing overrepresentation of Indigenous people in deaths in custody and violence from police towards Indigenous peoples. A lack of treaty. We still do not have a treaty with Indigenous peoples here in Australia, and as in many parts of the world, substantial inequities in terms of COVID infection, vaccination, treatment and outcomes. We certainly don't want to equivalize racisms or fall in the trap of equivalising Indigenous peoples with ethnic minorities peoples here in Australia. We don't want to do that, but we do want to highlight that people who come from migrant, refugee backgrounds in Australia do experience structural and interpersonal racism, one of which is that we don't actually collect ethnicity data in Australia yet, although there are moves with the new Prime Minister that may happen soon. And you can see here some examples of racism within the housing sector, within employment, again in terms of COVID, within workplaces. Excuse me. At an interpersonal level, children and young people who are Aboriginal and Torres Strait Islander report very high levels of interpersonal racism, as many as 50% of 10 to 15-year-olds in one study, with over 70% reported that they had witnessed their peers at school reporting racism, experiencing racism, sorry. For ethnic minoritized children and youth, very high levels of interpersonal racism, with certainly evidence that this has increased with COVID. A small study that we were involved with colleagues found that 85% of multicultural youth experienced at least one form of direct racism during 2020, when much of Melbourne was in lockdown. So how does this impact on the health of children and young people? To date, most of the evidence is focused on interpersonal experiences of racism, which is an issue we absolutely need to address within the evidence base. But that notwithstanding, a systematic review that colleagues and I completed a few years ago now, which we're currently updating, has found substantial evidence that direct experiences of racism experienced by children and young people have pervasive effects on mental health, such as anxiety, depression, behaviour problems, substance use and suicidality. And also that these experiences can get under the skin. They impact on chronic disease risk factors such as inflammation, obesity risk, cellular ageing, sleep, cortisol reactivity, and a number of cardiometabolic disease risk factors. I mentioned in one of the earlier slides about secondhand racism, these indirect vicarious racism experienced by a carer or family member, and also mounting evidence that not only has an impact on pregnancy and birth outcomes, but it can impact on childhood illnesses, child mental health, behaviour problems, and that much of this, of course, happens through the impact of these experiences on the carer's own mental health, on their ability to access resources, on the capacity that they have to provide the parenting and nurturing environment that they would like to be able to, because of their own experiences of racism at an interpersonal and a structural level. In terms of racism getting under the skin, here are a number of studies that I want to highlight to you. These are studies by Professor Jean Brodie, who's in Georgia in the US and has a number of cohorts of Black youth. And he has found, for example, in one paper, that young people who experienced high levels of discrimination at age 16 to 18, then at age 22, so 6 years later, had high allostatic load, which is a measure of global biological dysregulation. So their whole biological system was beginning to be dysregulated, which is a sign of early chronic disease risk. He also found that youth who were exposed to high levels of racial discrimination had higher epigenetic aging several years later, but only in those young people who had less supportive family environments, suggesting that family support and social support is a key buffer against the harmful biological effects of racism. And he also found that high levels of racial discrimination were associated with elevated cytokine, that's an inflammatory marker, 3 years later, but not among those who had strong racial identity. So there seems to be some effect, as other studies have shown, on other outcomes of racial identity being protective. In terms of younger children, there's one small study from the US among African American 10 to 15-year-olds showing that perceived discrimination, it wasn't racial discrimination specifically, but perceived discrimination probably was racial discrimination among these young people, was associated with CRP, which is an inflammatory marker, C-reactive protein, with blood pressure. And one of my own studies with colleagues, we surveyed 124 Australian children, 60% of whom were Indigenous or were from an ethnic minoritized background, and found that among those children who reported 2 or more experiences of racial discrimination, they had increased BMI, so body mass index, waist circumference, systolic blood pressure, and IL-6, which is an inflammatory marker and marginally associated with TNF-alpha, another inflammatory marker, all shown to be risk factors for cardiometabolic disease such as diabetes, heart disease, and stroke. I want to now move quickly to anti-racism in children and young people. What do we do about this? This is a report that colleagues and I know Roxanne Jones is there with you, a young Palomar woman and PhD student. Rox, maybe you can wave your hand if you're in the room. And colleagues and I worked on this evidence synthesis for Vic Health, the Victorian Health Promotion Foundation, and you can find the link to the report there, as well as a webinar, a fantastic webinar, which was co-designed and delivered by young people themselves. So 2 interventions that I want to highlight quickly. This one is called Speak Out Against Racism. It's a whole of school, multi-level, multi-strategy, school-based intervention to foster effective bystander responses in primary schools, elementary schools. And you can see there a huge research team, including Indigenous and people of colour, and it was funded by the ARC linkage grant scheme, along with 2 state education departments and the Australian Human Rights Commission. And so this was with school students who were aged 10 to 12 years at the upper end of our primary school. The key principles of SAW were to really focus on age-related cognitive skills and processing, to build racial and racism literacy amongst both students and teachers, and ultimately in the wider community too, to influence social norms regarding pro-social and bystander behaviour, to make a very clear delineation that bullying is different to racism. It was sustained over an extended period of time. It ran for 6 months. Very high focus on student engagement and leadership, and very much a train-the-trainer model. So school leaders and classroom teachers adapted the model, so were trained and then adapted it to their local school context. So this included a number of mutually reinforcing elements. So first was to target school policies and guidelines, so to try and get at some of those institutional and structural elements. And so there was a school audit tool completed by the school leadership team with then strategies for action developed by them. All classroom teachers involved in the program attended 2 one-day workshops where they learnt about race and racism, reflected on their own positionality, and then went through the classroom materials that they were then going to use within their own classrooms and adapt for their context. There was an 8-week unit of work that they went and delivered. And then at the end of the 8-week unit of work, students in each class formed teams. One school called them the Saw Patrol. That was the name the students chose for themselves, where student representatives from each class got together and co-designed and developed strategies for their school and the wider community about how they wanted to implement anti-racism. Quickly, some findings, because I think we're already over time. Quantitatively, we found with our pre and post surveys, you can read the paper there if you want more information or reach out to me. Really happy to discuss with you. We found that at the end of the program, participating schools had improved student pro-social skills and perception of the interracial school climate with no evidence of harm, which is really important. Actually, there is a perception that these sorts of interventions can't do harm, but they definitely can. And qualitatively, through our student focus groups and staff interviews, it was overwhelmingly positive in terms of both the process of the intervention, that it was fun and well structured and scaffolded, but also had impacts for students as well as for teachers. And we've got some quotes here which I'm not sure that we'll have time to go through today, but they're all in the paper. So teachers commented that it had built up their professional practice to talk about racism, something that they didn't feel that they were able to talk about before. That the students, this is a very popular quote, that everyone was nicer to everyone and that the interactions between students were much more positive. And also that they had the skills and confidence to intervene. As one student said, just showed us ways we could deal with it in our lives, not just the whole big thing of racism sucks and we need to get rid of it, without any practical suggestions. Next steps for this project, it was a surprise to me to find out that this program has been funded in our state budget, and I'm waiting for a meeting to find out what that actually looks like, but I think it will be implemented at scale in schools here in Victoria, the state that I'm in. We're also working, there's always constraints in the funding of these sorts of programs with government departments from the original grant to really strengthen the community governance and oversight of this through Aboriginal and ethnic community peak bodies and organisations. We've got a number of conversations happening in that space at the moment so that we can then refine the program and conduct a wider implementation trial at scale. And finally, I'd like to highlight this project that Kate Dory and my team, as well as some young people and colleagues from the Centre for Multicultural Youth, have been working on. And this was started in the context, I think it was a bit of a coping strategy for those of us who were in lockdown in Melbourne, where we've got the unenviable world record for the most time spent in a lockdown. And there was certainly some very strong elements of racism in terms of how that was implemented too. And so we worked with the Centre for Multicultural Youth first to conduct a survey of young people's experiences, and then also we received some funding from UNICEF Australia to co-design some focus groups and solutions with young people about what they wanted. And very much these young people have said we want safe spaces that are run by people of colour who understand our experiences and that they can go to, where they have the psychological support and that they're reminded that they're wanted, they're loved, they're worthy. Education in schools is very much a common theme that's coming through the focus groups on how discrimination affects people, awareness raising, understanding words like systemic racism and intersectionality. And similar actually what to the children were saying in the SOAR program. I guess a lot of people understand that racism is bad. They just don't know more about it because you don't really talk about this in high school. So, you know, you need to understand things a lot more, and so you just don't have to find out other sources of information when you're an adult. And finally, the young people in these focus groups have said, anti-racism, let it not be a fight of the minority. and really calling on white people, those of us who are not bearing the burden of racism but benefit from the privilege of being white. We need to speak out. It's not, anti-racism isn't just the responsibility of multicultural people. So with that, I'd like to acknowledge the enormous numbers of people. This is certainly not work that I've done on my own. I couldn't do it without mentors, colleagues, staff, community partners and collaborators and funding bodies. And if you have any questions, please reach out to me. And I wish you well for the rest of the conference. Thank you.
That was very, very sobering. The effects of race on our young people and children. And I suspect, and I know it's not just Australia. The same kind of impact would be felt on our children here. And I'm really sorry that Dr. Naomi Priest couldn't be with us, because she's an absolutely fabulous ally in this fight against racism globally. And on that note, I'd like to introduce Arnie. Where are you, Arnie? Arnie Puntis, who is now the, get this right, your title, the Research and Policy Manager at the RHO. Got that right. And Arnie is going to introduce her panel and have a discussion about some of what we've heard, the impact of racism on children and their health, which I think is something that we really, really do need to think about. Thank you.
Great. So, can I, is this working? Yeah, great. Can I invite my panel up? Come and sit with me. I don't want to be here by myself. Or come and sit here. Bit cold. Fantastic. So what I'd like to just start by saying is that for the online participants at home, please keep the questions coming in. We're going to try and make this as interactive as possible, so we can have a really good discussion. We've got what can only be described as like leading world experts in the field on this area. So it's an absolute pleasure to introduce you all. Just a bit of reflection about Professor Priest's plenary that she delivered. And I suppose it's really great to hear that sort of Australian perspective to start off with, thinking about, as a panel, what might be similar from the countries that you're from and what also might be different. But also thinking about how childhood really does set the scene. So, those kind of, we talked about maternity, we talked about, the sort of babies, but also the environments that they're born into, and then the exposure that they're getting. Not just from people outside, but also from their families and the kind of systems that they're being raised within. The other thing is that, that final quote, the kind of anti-racism, let it not be a fight of the minority. That kind of themes to me seem to be kind of coming through on this conference. It's not just for the people of colour to be doing the work, but actually as a collective, and to use that kind of hashtag of stronger together. We really, really are. So I'd like to begin by introducing Dr. Janet Smylie. I've got my notes here so I get all the titles correct. So Janet Smylie is from Canada. She is Director of the Well Living Action Research Centre for Indigenous Infant, Child and Family Health and Wellbeing. She's also a member of the RHO International Advisory Group. So with great pleasure, Janet, would you like to share your thoughts with us? Thank you.
Sure. Just make sure this is working. Not yet. Yes? Pass it around. This one's working. Great. So I'll say Tenzi Atawia, Kakia, Kitens, Gatunawau, Janet Smylie, Nitsi Kassin. It's a great opportunity to be here in the panel. We have a few minutes to speak to you and answer questions before lunch, especially after that talk by my esteemed colleague, Dr. Naomi Priest. I wonder if some of you are feeling a little bit overwhelmed and full. So I have some good news. The good news from my perspective as a Métis woman from what's now called Canada is the answers lie in our communities. So we've already heard hints of this, and we've heard hints about transforming curriculum. I'm going to actually suggest that we need to think about transformative models. So 3 points that I wanted to just introduce into the discussion, and I did have some slides. I don't know if they can magically appear. But if they can, that's wonderful. Thank you for that. And that wasn't magic. That's an amazing team here that's treated us really well and facilitated the conversations that have happened so far. So the first point is from my Indigenous perspective as a Métis Cree woman with a long and unbroken maternal kin line, which is relevant when we talk about child rearing. We actually had and still do have effective, evidence-based, sophisticated systems of raising healthy, happy children, right? And these systems are, where I come from, attachment-based. There's this lovely Cree word called aniskatastawin, which means attachment through the ages, where all people and things are connected. Imagine if we had that. We'd have no wars, we'd have no global warming, because we'd have attachment to the earth. Imagine if we had health services that actually built this aniskatastawin. They build in cultural continuity, which is something that's been hinted at, right? But this sense then, because we're dealing with racism that undermines a sense of well-being, of self-worth, right? And there's some evidence that self-affirmation actually can be protective, and they're strength-based. So one of my favorite examples, and as a GP that provided maternity care, and now I just say, well, there's enough Indigenous midwives that I don't have to do that. I like to talk about Indigenous midwifery. And this is my Auntie Maria Campbell. And the concept of Indigenous midwifery is bigger than prenatal care and 6 months after birth. And we've already heard there's good evidence to support midwifery as a model. But strong and gentle, wise and soft-spoken, laughing and singing. And again, maybe this sounds a bit abstract, not database, but these are actually examples, right, where pregnant people, childbearing people can feel safe, right? They're not weathering in these contexts, right? It's not building an allostatic load. So these people meant security for children, many interconnected community roles. They had medicines to treat sick children, counseled people who were fighting, taught culture through storytelling, attended to birth as well as death. So that's point number one. If I could see the next slide. Point number two, right, is that colonization has undermined these systems, which are diverse, but every single society in the world had intact systems that promoted attachment and that promoted child health and well-being, right? But part of the medicalization of our systems, right, is that we marginalized. So even here in the UK, there was traditional systems, right? And they built in some of these factors. I don't throw out biomedicine. It's helpful, to have access to some of these technologies. But the paradigm that we can draw on, the answers lie in our communities. So this is just a little figure that can talk about multi-generational cycles, right? And again, we've already heard this is a complex problem. There's racism at all levels. So we need complex solutions. Right, but here you can see the underlying determinants of Indigenous maternal health. So they include those social determinants that we hear about. There's a multi-generational family breakdown. In the city of Winnipeg, Canada, every day an Indigenous child is taken from their family, apprehended at birth, right? It's interesting because I was working on a grant, and one of the outcomes was actually to reduce that family disruption at birth. And the global funders from a very well-known organization, my peers said, well, I thought you were talking about maternal health. And so me and my colleague had to argue, well, surely apprehending a child at birth, right, is as significant a tragedy, or you could compare it to a perinatal loss, right? So it does have impacts, but in fact, that kind of gets ignored in the literature. So how do we break this cycle? So this is really just the third point. So if we could go to the next slide. So basically, and this is just one example of a conceptual model that I have been working on with an amazing team of Indigenous service providers in Toronto, Canada, where we have a birth center that's made for everybody, but it has an Indigenous governance model. We worked with an Indigenous housing provider. But just to let you know, there's this whole birth on country movement, Indigenous Midwifery movement. Maybe we'll hear from others around that. It's evidence-based, so there's a paper in the Lancet by my colleagues Yvette Rowe and Sue Kildee that shows increased breastfeeding and also decreased preterm delivery and increased access to care, so we can build in those systems. So those are just my introductory comments, and I'm anxious to hear what my other esteemed panel members have to say. Not sure, I probably used a bit more than my 5 minutes, but here we go.
Thank you very much. So I'd like to come next to Dr. Priscilla Reddy, who is an honorary professor at the University of UKZN Durban in South Africa, Centre for Critical Research and Race and Identity, and she's also an RHO International on our RHO International Advisory Group. So I'll hand the mic to you, but it'd be great to hear kind of similarities, differences, and your kind of take on the effect of racism on children and young people.
Thank you, and thanks to the conference organizers for inviting me this noonday. Thanks. Yeah, it was. I think Naomi's presentation was excellent in every way possible, but it raised many questions, because I guess South Africa kind of follows Australia, or Australia follows South Africa. I'm not quite sure who will get the trophy there, but one of us will. It's interesting to listen to the conference thus far. I come from an environment of colonialism, historic and current racism, continued racism into the future. But we're not an ethnic minority, we're the majority. Is anybody talking about this? Have we written about this? No. And the more I listened to Naomi's presentation, the more I thought about how do we start to think about racism and young people. They are the demographic dividend on the African continent, and certainly in South Africa. I've done several studies, and in every single study, the everyday hassle component or measures have come up very strongly for Black youth and young people. And how do they deal with it? I don't think we have the answers. I don't think we've started the answers. And I think our response, the response of denial, is largely because we don't know how to, and there's denial and denial and denial. So how do we confront in our young people, and how do they learn to cope with the effects of the 350 years of colonialism and the racism? Because technically apartheid fell in 1994. The 309 or 13 policies have been removed. Yet, if you look at the South African context, Black youth are the most unemployed. We have over 800,000 unemployed graduates looking for work. We've had studies with them, and they'll tell you how difficult it is because everybody wants experience. And then we open the door to the issue of, are they lazy because they're Black? Are they different? So those are some of the issues I just want you to think about. And as we move forward, we're going to have to think about how we deal with discrimination and racism in an ethnic majority. Thanks.
Thank you so much, Dr. Reddy. And yeah, those sorts of questions about in South Africa, what's going on and how we can change it for the youth that are coming through. And the kind of theme that's coming through a bit about that kind of ethnic identity of our children and young people, and the kind of importance of people being aware of their ethnicity and kind of being knowledgeable and being proud of it as well, and that kind of being a protective mechanism as well. So next I'd like to come on to Roxanne Jones from Australia, who's a PhD candidate and research associate at the Australian National University. She's a social epidemiologist and a registered nurse, and works in paediatric intensive care. So over to you.
Thank you, and thank you so much for having me. First, I just need to acknowledge that I am an Aboriginal woman. My family are Palawa people from the Lutruwita, Tasmania, down the southwest coast there. And it's important for me to acknowledge country that we are meeting on today, and also acknowledge that the Indigenous peoples here joining us, whether in the room or via video, their continued connection to land and culture. So yes, I have a background working in paediatric intensive care as a nurse, but really I left clinical work to pursue a research career specifically due to the racism that I experienced and the patients experienced, families. And so my PhD is looking specifically at children's and families' experiences of racism in that high acuity healthcare settings. And I think particularly, like, it's been really interesting hearing from Professor Naomi about the biological impacts of racism. And if we're thinking about not just the impacts of racism on the chronic health implications, but also, I suppose, in those high acuity settings. So Aboriginal children, for example, are twice as likely to die from sepsis in a paediatric intensive care unit. And there's other sort of structural, systemic issues that I'm really interested in understanding more throughout my PhD. And some of those are, Australia is quite unique in its vast level of remoteness in some areas. And for paediatric ICU, there isn't the infrastructure in every state or territory. So not only do you have the level of remoteness that some of our Aboriginal children have, but they actually need to fly interstate just to receive care. So how is that time when children, and we know that time is everything during critical illness, the time in which it takes not only to leave their community and access a tertiary hospital, but then they need to fly interstate. So how is that care disproportionately, how is the level of remoteness disproportionately affecting Aboriginal children? So these are some of the structural and systemic issues that I think we face in Australia. So they're sort of my initial thoughts and reflections from a combination of all of this morning's conversations. So thank you.
Fantastic. Thank you so much. And that point you make about sort of people that are living in those rural communities and how far they have to travel, and actually the support systems that might not be in place when they're doing that journey, and who are the people that are transporting them, what knowledge and kind of skills do they have, and that sort of level of cultural competence that we talked about earlier this morning. So I would love to ask you all of my questions that I have in my own head, but I won't be selfish, and I will come to the back where our team has got some online questions from the online people. So if you can ask away, please, Sam. Thank you.
Yeah, thanks, Ali. Can you hear me okay?
Yeah.
We have a question from our online audience. This one's from Monica. Can the panel think of any examples of successful culture change within large healthcare organisations that have led to improving health outcomes, in this case particularly for children and young people?
Thank you, Sam. So who would like to take that question? Don't all jump at once. So successful implementations, is that right, Sam? Yeah. There we go.
I can talk about a new institution. I think for those of us that work in large institutions, I've worked most of my career being affiliated with large academic teaching hospitals. I think it can come in fits and starts, though I think I've seen one video about a successful transformation in a hospital in the US. But one of my favorite examples is a birth center. I mentioned it briefly, the Toronto Birth Center. So there was a window of opportunity, because I think these transformations often occur when there is window of policy opportunity. And I had been working with people in the city of Toronto. There was a growing group of Indigenous midwives. We had high rates of cesarean section and a government that was trying to get re-elected in our urban centers. So there was going to be 2 new birth centers in Ontario. So we'd been already meeting and talking about the need for an Indigenous birth center in Canada. Indigenous infants are 2 to 4 times more likely to die in the first year of birth compared to non-Indigenous infants. In the city of Toronto, we have 88,000 First Nations, Inuit, and Métis people. So anyways, we'd already done a bit of preliminary work. At the funding announcement, actually, we thought maybe they were going to announce that there would be an Indigenous birth center in the city of Toronto, but I went in and knew it wasn't going to happen. I asked our premier, would they look at the unmet needs of Indigenous families and these infant mortality disparities? And he said, well, there already is 1 birth center in our big province of Ontario, and it is an amazing birth center in a First Nations community. It's very interesting how population-based resourcing kind of goes out the window. I'm glad I heard that there is a commitment by Sir Michael Marmot to make sure that there's needs-based resourcing for health here in the UK. But anyways, basically what we did is we had actually a little research project. We had a community gathering. There was this amazing group of energetic young Indigenous midwives with some allied midwives, and we put together a proposal because there was a tight timeline. We actually had a documentary film. So this Indigenous focused midwifery practice won the opportunity to create the birth center. So we have the Toronto Birth Center. I think they've just delivered their 4,000th baby, but what it did in our region of Canada, prior to that, midwifery had been really something that privileged people could access because it wasn't publicly funded, but now it is publicly funded. So it still has an Indigenous governance model. You can look it up, the Toronto Birth Center. There's all kinds of beautiful artwork in there, but it's for everybody. And 50% of the babies that are born in the birth center are Indigenous or are coming from socioeconomically disadvantaged, racialized pregnant people. So that's a beautiful example that I like to speak about. It says that you can use Indigenous models not only for Indigenous people, but for everybody and have good outcomes.
Could I just quickly add as well, and Aunt just spoke briefly about the Birthing on Country movement in Australia. So I think that was the immediate program intervention that I thought of immediately with that question. Yes, the movement towards Aboriginal women and people being able to birth on country has had a significant impact on preterm births and improving the outcomes for our young babies. So that was, one of the movements that I suppose has had a really big impact on our community at home.
I can't respond directly to the question, but I can respond more peripherally. I think in terms of involving young people, in particular, I guess a 15 to 25 age group, in terms of racism and their experiences, one way to both learn from them and to get them involved and to get them to act themselves is to integrate them into these interventions. Because I think from my experience, what happens is that researchers collect data, we publish the papers, but the recipients, the people that participated in the studies, don't actually get to hear the findings, and therefore they can't necessarily act. And I think if we just go to the 1976 uprisings of Soweto in South Africa, that was the start of the fall of apartheid. It was the young people, it was the school children that did it because they were involved. So I think if we talk with them and get them involved in the implementation of whatever it is we're doing, whether the health issue is a behavioral issue like using condoms for HIV prevention, but ask them how to do it and work with them to do it, I think we might see better results. Because what happens is it's the scientists and the health policy makers and the health programmers who develop these interventions, and they kind of the recipients of it. I think that model might need to be changed too.
Fantastic, thank you so much. So great to hear about those two sort of early life kind of aspects innovation and things that are different, and then also to hear about how we can empower our youth to actually be part of that change, and kind of reflecting on what Jacqueline was saying earlier about actually that sort of co-production and collaboration, and actually talking to the people to find out what will be effective. So we've got 5 minutes left, so are there anyone in the audience that would like to ask a question? If you have a question, please stand up and the roving mic will come to you. Yeah, got one here at the front.
Hello everyone, I'm Jabir Butt, Chief Executive of the Race Equality Foundation. We're also the organisation behind the parent education programme called Strengthening Families, Strengthening Communities. Lots of very interesting thoughts here, and thank you very much, Dr. Smylie, for your antidote to some of the other presentations here, because I do fear we may end up developing a victimology here, that children and young people are being done to rather than having any agency or any ability to address some of the challenges. And the worry I then have is that what we end up doing is focusing on interventions that perhaps deal with some of the symptoms rather than the things that really fundamentally would support those children and young people to not only react and resist and recover from the experience of racism, but be resilient to it as well. And I do think that we do need to think about the conversations that we have and make sure that in presenting our evidence that it isn't just about what the negative consequences are, but also how children and young people are actually resisting those and perhaps actually changing their experiences, but changing their communities as a result. And I think the reaction to George Floyd's murder, particularly not only in this country but across the world, suggests that children and young people are ready to show that leadership and to act. So I'm not sure this is a question, but more a plea. Let's not just see children and young people as victims, but actually see them as being the actors of that are going to bring about the changes that we want.
Thank you. Any sort of comments from anyone on the panel about that, or examples where you've kind of seen that in your countries or perspectives?
Sure. One of the quotes I like to share is by a beautiful Native American writer, Scottish Mama Day, and it's, "We are who we imagine ourselves to be." So I think that's a really important thing to think about. And I'd like to think some of the Indigenous youth have trained me up all right. They still find I'm a pretty deficit base, but I've done some work with an inspiring group called the Native Youth Sexual Health Network, for example. And I feel completely confident and inspired when I'm with youth, though of course my responsibility will be to make sure that they get the resources they need. Native Youth Sexual Health Network actually talks about direct funding to youth organizations, so they can actually, so some of that is really not only having youth at the table, but making sure that they are decision makers and they have autonomy and resources.
Sorry, I'm going to have to sort of bring our session to a close, but there's such a wealth of knowledge here that we'd really like to sort of pick up on. So if there are any more questions, then please post it on the chat online. And what we'll do is be able to collate those so that our experts can then respond to those over the next month or so. So thank you so much to our panel of experts. Thank you very much.